Good afternoon, I'm Melissa Jew with Dignity Health, and we're here today at the Mercy Medical Group J Street location, which is right next to Mercy General Hospital. I'm here with Dr. Munir Janmohamed. He is the Medical Director of Mechanical Circulatory Support and Heart Failure here at Mercy Medical Group and the Dignity Health Heart and Vascular Institute. And his patient, Anthony Robinson, is joining us today. Thanks for joining us. He was diagnosed with heart failure, so we're going to talk a little bit about Anthony's journey and also everything you need to know about heart failure. So thank you both for joining us today. Let's start with a basic question for you, just to sort of set the pace here. What is heart failure, and are there different types?
Yeah, so heart failure basically is a disorder of the heart muscle. So I have actually a model here basically, and you have, these are called your ventricles. There's one on the right side and the left side. And heart failure basically is a disorder of the heart muscle. So it can be where patients have problems where the heart doesn't pump normally, or it can be a patient with a problem doesn't relax normally. Anthony had the type which is called heart failure with reduced ejection fraction or systolic heart failure.
Okay, all right. And are there different types? Can you mention some of the other types? Or?
Yeah. So as far as the different types, there's basically problems with the pumping ability or the relaxing ability of the heart. There's a lot of different causes for heart failure. The most common cause is what's called coronary artery disease, or even having a heart attack. So basically, you can see here on the model, you have all these vessels in red here. These are what's called coronary arteries. They supply the muscle. They provide blood and nutrients to the heart muscle. And if you, let's say, have a heart attack, then the heart muscle can get damaged and it can cause heart failure. Other causes include high blood pressure. Patients have any type of problems with their valves as well too. Sometimes patients may have a disorder of the heart muscle itself. So there's quite a large list. It could be also to a fast heartbeat. And then also, it could be also drugs, recreational drugs and methamphetamine, or even like cancer drugs, for breast cancer or also leukemia as well too.
Oh wow, lots of different types. So Anthony, what were you experiencing? What were you feeling? What were some of the symptoms that made you think something is wrong?
Well, I thought I just was sick, actually, like I had a flu or something, because this happened in February. And I, just I take my dog for a normal walk, and I was literally just exhausted after going maybe a block. So, but I thought it would go away. I was stupid about it, frankly. I should have come in sooner. And I went to my primary care, and then he said, get to the hospital. And then I was admitted immediately. They ran some tests, and I was in atrial flutter. And they did the cardioversion that got me down a little bit, but not where we needed to be. Then we did the Lexi scan, and then we did the cath lab, and that's where they found it from here.
So are those the typical, ways you get to be diagnosed?
Yeah, so I think starting with his symptoms, so the symptoms he had is kind of shortness of breath with activity. So really the reason why he developed that is because your heart is a pump. In his case, it wasn't pumping adequately. And then basically if it doesn't pump adequately, then you can build up a fluid in the lungs, and that causes congestion and lead to symptoms of shortness of breath, which he had. In addition, you mentioned he had a very fast heartbeat, something called atrial flutter, which caused him some palpitations too. When he came, he was a very fast heartbeat, which he got shot back to normal rhythm. And as part of the workup, like he mentioned, the way we diagnose heart failure is what's called an echocardiogram, which is an ultrasound of the heart. And the ultrasound of the heart, that tells us a lot of information about what the heart function is, what the valves are doing. So we started with that. That's when he was diagnosed with a weak heart. And then the next step was what's the etiology. And so, as he mentioned, we did what's called a heart catheterization, make sure all his arteries are okay. So we did a heart catheterization, came back okay, and then he was then placed on appropriate therapy for heart failure.
Okay, well, we should mention, Anthony, that you're a personal trainer.
Yes.
So you're in good shape.
Yeah.
And you're young. So
relatively.
what went through your mind when someone says heart failure?
Shock, despair, confusion, sadness, anger. I mean, pretty much the whole gamut of emotions. Go there, this can't be real. Like, how the heck did this happen to me? I didn't see this. I mean, I literally worked out 2 times a day. I eat right. I do everything. I get other people healthy for a living. So it just seemed totally counter to what I had, what I thought was going on. So it was really a shock, and kind of a shock for the first, a few weeks of it, just trying to process this information as the changes and whatnot.
Yeah, and so are there risk factors that Anthony had, or that?
So we went through the usual process of looking at the common causes, like we talked about. Heart disease, we kind of ruled that out. We checked his thyroid as well too. Really everything came back okay, really. The only thing we can figure out in his case basically was he did have this fast heartbeat, which could be, sometimes you have what's called tachycardia-mediated cardiomyopathy, which means a very fast heart rate can cause a weak heart. So that could be one possibility, or sometimes we don't know. It's labeled as an idiopathic, so we may not know exactly what his etiology was.
And does age have anything to do with heart failure?
Not so much, yeah. So I would not say age, but I would say like heart failure, the diagnosis, the age is usually an older population. Because what's happening now is as we're improving our techniques of fixing blockages, patients are living longer after a heart attack, but they're living with heart failure. So if you look at the average age of a heart failure patient, actually quite old. It's about 74 is the average age.
Oh, wow.
Yeah. So he's off the other
Yeah.
spectrum, you know.
Yeah,
So
46.
but he wasn't our typical patient, but obviously had a great outcome. So.
Yeah, so treatment of Anthony, what kind of things did you do?
Yeah, so basically for this type of heart failure, there are actually multiple large clinical trials that showed certain medications that have proven to be effective, both improve symptoms and also survival. So basically what happens to all of us, we have basically hormones in our body, and particularly in heart failure, they actually are overactive, and they actually cause damage to the heart muscle. So we put them on some standard medications. I'm sure you remember something called beta blocker and something called lisinopril, and also diuretics. And I think you can kind of talk about how you felt when you were on those medications.
I mean, it was, I really, after probably 2 months, I really felt back to normal, but I know I wasn't. We had another echo done.
Right.
I know we're expecting it to be higher, and it was when I came back at 35, so that was more mentally trying to process, okay, I thought I was going to be higher,
Yeah.
but physically, I mean, I wasn't getting tired anymore, I was able to get back to doing things, really attack my cardiac rehab that I did, and then I was supplementing that with more exercise, but I was just I was discouraged at first when that 35, but then I also said it's a small window, so let's give it that more time, and then we were back up here,
Yeah.
2 weeks or 3
Yeah,
weeks ago.
yeah. What he's talking about is what's called the ejection fraction. So when we do the ultrasound of the heart, we actually measure the contractility of the heart, and normal it's not 100%, it's 55 or above, 55% or above is the ejection fraction, which is the contraction of the heart. So when Anthony was first diagnosed, he was around about 30%, 25 to 30%. And what we do is basically we put patients on medications and we serially follow their ultrasounds of the heart, echocardiogram, and we see what the ejection fraction is. And that's what he was mentioning. So we did one a month later, and his ejection factor was still about 30%. So that's what he was saying. The good news is that actually really it's very powerful is how patients are doing, and he had felt dramatically better. So right then I kind of knew. Obviously it was discouraging for him, but in my mind I knew that he was on the right track. And then subsequent ultrasounds of the heart actually showed he's actually now normalized his heart function. So good news, and maybe he's doing great.
That's great. And any other lifestyle changes, adjustments that you made?
Obviously reducing sodium, that wasn't too hard for me, because I eat pretty healthy anyway, and I cook most of my food, but I cut out caffeine, and that was a totally different story. So I haven't had a caffeinated drink since February, so I'm gonna decaf. I guess there's a little caffeine in decaf, but nothing. So that was probably the biggest adjustment for me is just like I just enjoy coffee, and I think maybe what got me there. I enjoy coffee too much. Maybe that's what caused the original.
Yeah.
You have a cup. You have 1 cup now.
Okay, good.
So you feel great?
I feel great. Like I came from when I was at the gym this morning. I did 10 miles of interval on the bike. I rode 3 miles with the rower, and I lifted weights already.
Make it
Whew.
look
I know.
bad. Yeah.
Yeah, so I just figured, I don't know, nothing's promised, but I figure I'm doing well now. I'm gonna enjoy life and live it to the fullest now. Because I wasn't really sure when I first met you. If I just had a birthday last month, and I didn't know if I was gonna make it to that birthday.
Yeah.
So I don't know. I mean, I feel great now, and I'm super thankful to Dr. Janmohamed and the whole team. They've been fantastic. Everybody here at the hospital and cardiac rehab, all the team's been really, you feel like you're not just a patient or a number there, it's like you feel like they really care about you as a person. I appreciate that.
That's great. So you must talk about what happened to you, right?
Yeah.
So what do you tell people? What's your message, I guess, when people ask you about your journey?
In terms of this, I mean, obviously everybody's different in terms of what's going on specifically, but I think you control the things that you can control, and just kind of let the experts deal with the other things. So the things that I control were my outlook. Now I had days where I was down, I was depressed, I'd be driving, I'd break down in tears, and I'd pull over. I mean, I totally had those days, but I never lost faith in the fact that I would heal. I don't know if that doesn't mean it's going to happen, but I know that I'm going to be here forever, long I'm going to be here, and I'm going to live positively, and I really think just from experience, where the mind goes, the body tends to follow. So if you go with this negative outlook, like, oh, woe is me, this is going on. No, I had those days, but that was it's more like the 80-20 rule. If I keep 80% positive, then I'm good. And those are the things that I focus on. That's what I tell people. Like I have clients that I work with as a trainer. I deal with a cancer patient. I have this, all these other people. I tell them the same thing. Medicine's going to do what it's going to do, but control your mind there. That's the best thing you can do for yourself, to stay in that state and be positive about things and just encourage yourself, because it's easy to get down. You're going to have days where you're going through this where you do get down, but don't stay down. Just keep your mind right and trusting that they've got a great team here and they're doing the best for you. So.
Any other words, Dr. J, about Anthony?
Yeah, no, definitely. I mean, I think like it was easy, obviously, when you have a great patient like Anthony. Really, I mean, I think that the key thing is that he was very vigilant about his salt. He also knew his condition. I always try to educate my patients to understand what their condition is, what the medications are, and to really empower them. And then the next step, like he's pretty standard. He went through these stages. Like accepting the diagnosis, to living with heart failure. And not letting heart failure take over his life. He just mentioned it was his birthday and went to take a nap or something. Now what's happened is you want we want to learn how to live with this condition. You don't want heart failure to take over your life, but it's a process, and so I think that's the advice that he gave. You're going to have these ups and downs, but try to be positive. That's what I encourage my patients. I'm very positive with all my patients. I always think I can make any of them better. I try my best. We tackle along the way. And in his case, it worked out very well. So I'm very happy for that.
Very good. We're very happy. You have very good advice.
Oh,
We're going to steer the conversation to things that you didn't have to have for your heart failure right here. So we appreciate you coming and sharing your journey. Thanks so very much. Yeah. Best to you.
All right. Good luck, everybody.
So what do we have here, Doctor?
Yeah. So basically, what happened is that. So when a patient is first initially diagnosed with heart failure, we put them on medications and we see how much their heart function improves. And after about 3 months, we repeat another ultrasound of the heart and we see what the heart function is. If the heart function is less than 35%, their heart is at risk for what's called an arrhythmia, which could be potentially fatal. You probably see at the airports, these defibrillators at the airport.
Yep.
So we basically implant an implantable defibrillator, and this is kind of what it looks like here. It basically gets placed inside the body with attached to some leads, and it goes inside the heart. And basically, its role is kind of like a guardian angel. And basically, it's monitoring your rhythm, and if it detects anything abnormal, it'll give you potentially a life-saving shock. So this is what's called an AICD or defibrillator. And we kind of reassess the patient's heart function at 3 months, determine if they need that. Sometimes, depending on if they have what's called desynchrony, or kind of like an abnormal contraction of the heart, they get a little fancier one, which is pretty similar, has a defibrillator, but also has a pacing feature. So basically, what I mean by desynchrony, you have these two pumping chambers we talked about here, and some patients have where they don't pump together the team. And sometimes you can get a fancier one where you have now, instead of 2 leads, you have 3 leads, so these can pump together, and these can make patients feel better and actually improve survival. So that's kind of the next journey in the patient with heart failure, is after they're placed on medical therapy, we do another ultrasound in 3 months and decide whether they need a defibrillator.
Okay. All right. And
next.
How long does that last?
So these, so depending on, it has a battery, obviously that has a shelf life, but depending on the use of it, but it can be several years. I mean, if a patient doesn't have any type of therapy given, it can last 7 years. But depending on how much they're using it. So
do you need to go around at TSA, or what kinds of things do you do that are different?
Yeah, so basically, as patients have these devices, we give them a letter in case they have to go into Meditech or anything like that.
Okay.
But most times that's not pretty well tolerated.
All right.
Yeah.
All right, and then next is in the progression.
Yeah, so basically we always follow these patients pretty regularly, usually about every 3 months, and we look for any progression of heart failure symptoms. And what we're looking for is any worsening shortness of breath, any heart failure admissions for heart failure. And sometimes that's the case, we actually can implant a sensor. So I don't know if you can show it on the camera here. It's very small here. That's how small it is, basically.
Yeah.
But this gets implanted basically through a procedure through the groin, and it goes inside what's called a pulmonary artery. So it goes inside the body over here.
Yeah.
And what this does actually measures the pressures inside the heart. Because what happens, we talked about, is that when your pressures go up, patients develop symptoms. And so this sensor will kind of tell us the pressures. I can log into my phone or computer. I can see the pressures in the patient.
Oh, wow.
I can act on it by changing their water pills and reduce the pressures, hopefully save admission for heart failure. This has actually been proven to reduce hospitalizations for heart failure.
That's awesome.
Not everyone necessarily needs this, but sometimes when it's a little tricky to manage their fluid status, this can be used as well too.
Okay, wow, that's great.
It's called it's called a CardioMEM sensor. It's been very impactful in our field.
Yeah. Okay, and then here is
exactly. So basically, we talked about the problem with heart failure. It's a pump issue, and sometimes what happens is, unfortunately, we have no cure for heart failure. We have a lot of great medications. We have all these fancy devices, but sometimes the pump can progress and actually lead to what's called advanced heart failure. And some of the clues are, recurrent hospitalizations for heart failure. not tolerating medication, shocks from a defibrillator. These are all some clues that we look for.
Mm-hmm.
In that case, sometimes we have to see whether they're candidate for either a heart transplant or something called an LVAD. This is what an LVAD basically is. It's a surgically implanted pump that gets placed basically attached to the left ventricle.
Mm-hmm.
So we talked about here on the heart here, it basically connects to the heart here on the left side, and you can kind of see what it looks like on the inside here. It has basically an impella, so basically blood goes in, gets propelled forward, blood goes in here,
Yeah.
gets propelled forward into this tubing here, and this basically goes into the aorta, basically bypasses the failing left ventricle. And so this can be used as either what's called a bridge transplant to get to the ventral goal,
Mm-hmm.
or something called destination therapy. So we know that transplant numbers have stayed relatively stable for the last 15 years.
Mm-hmm.
There's only some certain amount of donors. So previously, patients would sometimes unfortunately die on the transplant list before they got their transplant. So this actually is a nice segue to get them to their transplant.
Right.
Or even patients that are older. We talk about the average age of heart failure is increasing. So you can actually use these therapies as what's called a destination therapy, and someone that's above 70, for instance.
Wow.
Yeah.
So this is a little more, it's complicated, but
Correct.
so what are there any
Yeah.
lifestyle changes you need to make
Yeah,
with this?
yeah. So the biggest thing, the biggest thing you can see is the Achilles heel. Basically, is this drive line here.
Yeah.
So basically, this is going to come out of the body, basically.
Okay,
So the potential,
just
and yeah, so
cram their feet
yeah.
in there.
So the biggest
Yeah.
thing is they can't swim.
Right,
So you
okay.
have an exit port. So and that is unfortunately important to some people. That being
Mhm.
said, when patients are this sick, really, unfortunately, their survival is very poor. And so most patients, they're able to accept that, not be able to swim because they're able to live.
Shower?
Shower. Eventually, once after a certain amount of time, they get shower bags, or they're able to shower as well
Oh, okay.
too. So that's it. As far as other things, lifestyle, these basically requires power. So at home, they're connected to like an AC power.
Okay.
To connect, this is a pump, but like in your house, you have a fan. It's the same
Yeah.
thing. There's a motor in here. When you go out, basically, you have to carry batteries, and that kind of will power you for about 10 to 12 hours.
Oh.
And that's how it powers this pump basically. So it's an evolving technology. It's been around for many years now.
Mhm.
It's improving. Certainly, hopefully in the future we'll have a fully implantable pump as well too. Kind of like your iPhone, you charge it on a mat. We're gonna have a similar technology here. So the field is growing quite a bit. You can see I'm very fortunate to be in the field that I'm in heart failure because I have all these tools at my arsenal. For
Yes.
medications, prevention medications, so these devices, sensors, and then patients for the very sick as well too. So.
What should caregivers know about heart failure? You work with the patients
Yeah.
a lot. I'm sure you work with the caregivers as
Yeah,
well.
so it's a good question, because it's obviously very taxing on them as well too.
Mhm.
I always tell the caregivers and the patient both, kind of to know their condition, know what signs to look for, and also provide support for them too. Actually in our clinic, we actually have a social worker that comes in and sees all of our patients.
Mhm.
Sometimes we forget that, like Anthony mentioned, depression is very common in our patients, and
Yeah.
sometimes even in caregivers. So we always try to screen for that as well, to provide support and emotional support even to the caregivers as well too. So I basically would encourage them to understand their condition and also know certain things to look for.
Okay. I think Nicole has a question.
Yeah, so we have a couple questions kind of going back to risk factors.
Sure.
So the first is, do people with heart failure have a history of heart disease?
Yeah, so I forgot to mention, so there is a genetic cause for heart failure, so some people can have a genetic predisposition to developing heart failure. Also, if you have a family history of heart disease, that can predispose you to, let's say, heart attack, and we know that can cause heart failure. So yeah, if you have a family history of, let's say, heart disease, let's say your father or mother, it's good to probably know your cholesterol and your blood pressure and just prevention, for preventing something from happening.
And are there different risk factors for men and women, or is that pretty much the same?
No, pretty much the same for both groups.
And then what are the different signs a heart attack is coming on for men and women?
Yeah, so, good question. So, typically the symptoms are going to be, chest pain, pressure-like pain, going to the arm or the jaw. Sometimes women can have symptoms where it's more abdominal pain as well, too. But the symptoms are pretty similar, but there are some slight differences.
Listen, you're really passionate about heart failure. Why did you decide to go this route, from a medical doctor perspective?
Yeah, early on, kind of like before I did cardiology, I was able to spend some time with a great mentor of mine at another institution I trained at.
Mhm.
And it's a chronic condition in cardiology. You really get to know these patients, from the beginning. Like Anthony, I still remember when I first saw him. I remember what room he was in. I remember all that he was telling me about the kind of the emotions that he had, the diagnosis as a young guy. And I kind of see through his journey. Now I'm seeing, like I said, last week went to Napa. That's what we do, that we you have to have stories like that, so it's like a chronic condition which you're able to make a big impact on their life through all these different therapies, So I think that's what I really enjoy about heart failure, that there's a lot of options for patients. You get to know your patients very well.
Yeah, and you mentioned chronic disease, so a lot of people are living with heart failure.
Yeah, definitely, for sure. Like I said, we unfortunately don't have any cure. We're working on definitely some good medications in heart failure. Patients are living longer with heart failure, but unfortunately there's still no cure, so they're definitely chronic patients. But we hope to stabilize them, and hopefully they continue to do very well.
So if you wanted to leave one message to the folks who are viewing this right now, what would it be? What kind of message?
I think the message we talked about, it's all about prevention, really. I think we talked about all these fancy therapies, but know your risk factors. We talked about risk factors like know your blood pressure, what your cholesterol is. Don't smoke. Obviously, methamphetamine is very common in Sacramento. So all these certain risk factors reduce your risk of developing, let's say, heart disease. Which is the most common cause for heart failure. So that's what I would definitely recommend.
And then one more question, kind of to piggyback on that. So there's no cure, but are there things patients can do to manage this condition?
Yeah, for sure, definitely. So I think it starts with, like I said, I always want to empower my patients to understand their conditions. I want them to, I always ask them to write down their medications and know what each medication is for, so they kind of know, understand what their condition. I always ask, what is your understanding of your conditions? I want them to know about that. And then as far as and then the medication. So I think that even though there's no cure, but you, like I said, you learn to live with heart failure. I don't want heart failure to take over their life. I want to basically they just wake up, they brush their teeth, they take their pills, and they go on their day. That's what I want them to get to that point. I don't want them to be focused on heart failure the whole day. And I always encourage my patients, go back to work, go back to your daily activities. Doesn't mean you have to stay at home. So.
Good message.
Yeah.
A lot of good information today. I should point out that this entire segment will be posted on the Dignity Health Sacramento Facebook page. If you want more information about Dr. J, he is on mymercymedicalgroup.org. And if you want more information about the Dignity Health Heart and Vascular Institute, you go to dignityhealth.org/Sacramento, and you click on Heart and Vascular. So thanks so much for joining us today. Very informational. Really appreciate it. And we'll see you next time.
All right. Thank you.